So it is my great pleasure this morning to introduce Kathleen R. Becker, JD, MPH, here as our candidate for the UNM Hospital CEO position. Kate Becker currently serves as the president of SSM Health in St. Louis University Hospital, or SLU. SLU is the primary teaching hospital of St. Louis University. It's a level 1 trauma center. It provides the tertiary and quaternary care for the services for patients throughout eastern Missouri and southern Illinois. As president, she's responsible for continuing to improve quality, safety, growth of SLU's exceptional medical services, and deepening the alignment and relationships with the physicians of St. Louis University and strengthening their patient, physician, and employee satisfaction. But Kate brings a very distinguished career to us today. Her other roles have included her serving as president of SSM Health Cardinal Glennon Children's Hospital, which is also a level 1 trauma center and was the primary pediatric teaching hospital of St. Louis University. She, during that time, or a portion of that time, was also president of SSM Health St. Mary's Hospital in Richmond Heights, Missouri. That hospital was a 525-bed community teaching hospital. Before joining SSM Health, Kate was the CEO of SLU Care, which was the faculty practice plan of St. Louis University, something equivalent to our UNM medical group. In that role, she was responsible for coordinating the strategic, administrative, and financial objectives of the faculty practice plan. Kate has a very long list of community activities to include board memberships and volunteer work. She brings to the table an educational background of a bachelor's degree and a master's degree in public health from St. Louis University and a Juris Doctorate degree from the Chicago-Kent College of Law. With that, I'm pleased to welcome Kate Becker to the stage.
Thank you, Mike. So I have on 2 microphones. I'm checking to see if they're both working. Okay, great. So as Mike said, I'm Kate Becker. Thank you for taking the time out of your day today to come talk with me. I appreciate the opportunity to be here. Our topic today is the academic teaching hospital of the future here at UNM hospitals and in our community. But before we turn to that topic, I'm going to tell you a little bit more about myself, a few of the things Mike mentioned, and ask a few questions of you. So a little bit about me. I was born and raised in St. Louis, Missouri. My mom's from St. Louis. My dad is from Albuquerque. And I spent many vacations and holidays visiting my grandparents here in Albuquerque. My grandparents owned a drugstore here, Sandia Drug, and my grandfather was the pharmacist, and my grandmother ran the store. So I'm really happy to be back in Albuquerque and to be a candidate for the CEO position here. Some of you who've interviewed me before and have met me have heard this story, but it's been kind of nice as part of this interview process to learn a little bit more about my family story. And one of the things I learned that my grandfather, Frank Riley, was one of the first presidents of the New Mexico State Pharmacists Association in the late 1940s. So in that role, he actually traveled the state with the dean of the UNM College of Pharmacy, which we can see right out the window here, raising money for scholarships for needy students for the College of Pharmacy. So that was kind of a nice connection to make, sort of neat. As Mike said, I have a master's in public health and a law degree, and I've been working with doctors and hospitals in community and academic settings for more than 20 years. I started as a lawyer in medical malpractice cases, defending doctors and hospitals in Texas and then in Missouri. What I learned from that work was how to build relationships with healthcare providers and how to tell their stories. And then I moved over to the administrative side, became the CEO of a faculty practice plan. And what I learned from that work was a little bit about how challenging it is to be a physician today. Then I moved over to the hospital side, first at a large community hospital with a teaching component, then a children's academic hospital, now an adult academic hospital. Our current hospital is a level 1 trauma center for Missouri and Illinois. We serve patients from about a 250-mile radius of St. Louis. And what I've learned from that work is a little bit about the financial and operational complexities of hospital work today. I love this work. It gives me a chance to bring some of the things I've learned over the years about communication, working as a team, all in the context of how we improve health outcomes for all of us. So that's a little bit about me. Now, if it's okay, I'd like to ask you a few questions. By a show of hands, how many of you work for UNM hospitals? Awesome. It's probably 90% of the people here. How many of you work for the Health Sciences Center other than at the hospital? Great. And how many of you trained here? Either went to school here, did a residency here, anything? Great. So we who work in hospitals, it's our workplace, right? It's normal to us. We come and go every day just like the teller does at a bank or the construction worker does at a job site. We're comfortable in that environment. And sometimes we forget that every other person there, every patient, every visitor, every family member is nervous. They're afraid, maybe confused, in pain. So I have one other question. How many of you have either been a patient yourselves or had a family member who's been a patient here at UNM hospitals? Thank you. If you've had that experience, if you've shared the experience our patients have, you understand how much it can mean when somebody takes that few extra minutes to listen to you, to explain something, to be kind, even just to smile. And so I think having had that experience, I appreciate you sharing that. And let's think about that a little bit as we talk about the academic teaching hospital of the future. So first of all, let's talk about what makes an academic hospital different. We're just a hospital, right? What's different about us? You already know this, but sometimes it helps to say out loud who we are and why we do what we do, right? There are 4,800 hospitals in the United States. But according to the American Association of Medical Colleges, fewer than 10% of them are academic teaching hospitals. All 4,800 of those hospitals have as their mission delivering clinical care to their community. And I'm sure that all 4,800 of them want to deliver safe, high-quality clinical care. But the first thing that makes us different is how we define community. For a community hospital, for those thousands of other hospitals, community is defined by proximity. It's who lives near us. We're called to serve the patients who live nearby. For academic teaching hospitals, community is bigger. We're not only called to serve our neighbors who live nearby, but we provide highly specialized care that's only available in some places, and we're called to serve the many people who come from afar to access that care. We're only 10% of the hospitals in the country, right? But nearly half of the organs transplanted in the United States are transplanted at academic teaching hospitals. We comprise 60% of the level 1 trauma centers. And 2/3 of the burn beds available in the US are at academic teaching hospitals. Those are just a few examples of the specialized care that we provide that are part of why our mission is different. There's two other ways our mission is different. We have that one strand of clinical care as part of our mission, but we have two more that we have to weave together. We have a mission in education, and we have a mission in research. So our mission in education calls us to train the healthcare providers of the future, doctors, nurses, allied health, other providers. Our mission in research calls us to increase the knowledge available to our providers and to the community. New cures, new treatments, new ways of using the knowledge we already have. So those three missions are what make us different. How do we weave those together? How have we done that in the past? How do we do it in the present? And how will we do it in the future? So if you look at the past, I think we could say we had a very disease-focused model in all three of our missions. In our clinical care mission, the provider was focusing on the specific disease the patient had. And usually it was only the disease of interest to the specific provider. In our educational mission, we were training folks to focus on disease, to specialize and subspecialize. And in our research mission, again, we're focusing on going more deeply into specific aspects of specific diseases. Our patient and family education didn't really help patients connect those different providers and their different plans of care. Our technology didn't support how we connect across providers and from providers to patients. And even though every provider was doing their absolute best possible work, and every patient may have followed every potentially conflicting direction they got, we weren't necessarily providing the best clinical care we could provide. So that's the disease-focused model. That's the model of the past. Over the last 50 years or so, it's evolved considerably. We started recognizing those gaps in quality and thinking about how can we address those? What can we do? The whole healthcare system is thinking, how can we improve quality? In 1966, Dr. Domenici published his groundbreaking model of how to measure the quality of care delivered. In 1970, the Institute of Medicine was established. In 1989, the Agency for Healthcare Research and Quality was created. All of these different ways to think about how do we measure quality, how do we improve care, how do we make it better. At the same time as that's going on, the payment model is shifting. So in the disease-focused model, we had a payment model where it was really specific focus. Every patient, every disease, every interaction, payment after payment after payment. And as we move into the present, we see the model shifting. Payment for a single diagnosis in a hospital stay. Moving towards bundling payments across care settings for a patient and across providers. Shifting towards risk-based payments. So it continues to evolve. Our technology is evolving. The electronic medical record arrives. The internet enables us to do virtual visits and telehealth. So all of these changes in quality, in technology, in payment models, they all impact all three parts of our mission. In the clinical care aspect, when we think about how is that goal to improve quality changed, we've begun to really think about how do we improve connectivity and communication between providers? How do we make that work better? In the educational model, we've begun to think about how do we teach team-based care? How do we teach folks to consider social determinants of health? In the research strand, we started thinking about how do we research the way health outcomes are different in different populations. So we're evolving. We're changing from the disease-focused model. So what does it look like in the future? Well, let's look at it in all three missions and think about that a little bit. In the clinical care model, I believe our first priority has to be safety and quality. I believe that our challenges in safety and quality are real. They're connected to our challenges in communication. Academic teaching hospitals struggle to maintain high safety and quality ratings. If you look at Leapfrog, pretty commonly accepted measure, it's hard for academic teaching hospitals to get above a D or a C. Why is that? It's communication. It's partly because we have a very hierarchical, segregated, some people say siloed structure in academics. It's partly because of how we think about how we approach the care of the patient. Is it disease focused that we're doing? Or is it patient care focused? So let's talk about communication a little bit and how we can change that. Let's take multidisciplinary rounding as kind of an example. So multidisciplinary rounding. Sounds easy, right? Proven technique. improves patient satisfaction, improves outcomes, improves care coordination. Why is it so hard for us to do in a teaching hospital? We should just do it. We know it works, right? No, it's hard because we have different services, they have different schedules, everybody's got a conference at a different time. Who's going to be where at any particular time is hard. It takes an enormous amount of commitment and communication to coordinate that and to consistently practice it. But I believe we have to figure out how to solve those kind of problems. We have to make a commitment that collectively, physicians, staff, using again multidisciplinary rounding as an example, we're going to figure out the calendar coordination issue. We're going to identify the unit or the floor or the cohort that we're going to be rounding on. We're going to set the time and we're going to communicate it, not just among ourselves, but to our patients. We need to use our technology better. And actually, with the electronic medical record, means using it both more and less, right? So on the one hand, we have a ton of data. We have so much information available. But we don't always allocate the resource to analyze that data so it's useful and actionable. On the other hand, we sometimes think that a note in the electronic medical record is a substitute for face-to-face communication. And sometimes that face-to-face communication between providers can be the more efficient, more thoughtful, faster way to get to better care for a patient. We need to manage our cost. We need to be more efficient. So how do we do that? There's some obvious things, right? Reduce waste. Figure out how to operate more efficiently. Do better contracting for supplies. But there's some overarching things too, right? How do we make sure care is being delivered in the most appropriate setting? At this end of the spectrum, how do we make sure the patient who needs a primary care relationship doesn't have to access that care in the emergency room? All the way to the other end of how do we make sure that patient who needs specialized care like trauma has it available to them? We have to partner with our communities. We have to listen and figure out how we're making sure that access to care is available and affordable. So thinking for a minute about listening. There's a term in educational research called funds of knowledge. It's a little bit different than the way we talk about it normally. The concept essentially is that every interaction, the people to the interaction both bring information, and that information is valuable. So how does that apply in medicine? In the disease-focused model, healthcare providers have a tremendous fund of knowledge. The disease, its causes, its treatments, outcomes. But we may not always have considered the fund of knowledge that patients and families bring to those interactions with the care that we could have. How do we, going forward in our clinical mission, in our education mission, use that fund of knowledge the patients bring about what's typical for that patient? What are their circumstances? What community supports do they have? Because all of those things impact the likelihood of success of any treatment or prescription. The academic teaching hospital of the future has to figure out how to integrate that. Let's talk a little bit about the education strands, or if you think of that three-part braid, clinical care. We've got to get better at communication. We've got better at coordination, better at managing cost. The educational strand. It is an incredibly difficult time to choose to be a healthcare provider. The American Hospital Association's 2018 environmental scan, 49% of the physicians surveyed said they often or always experience burnout. The healthcare model is in flux. Providers and payers are trying to figure out new care delivery models and new payment models. And the cost of entering these professions is substantial. The average state medical school tuition is $35,000 a year. And the average medical school graduate has $150,000 in debt. Even here at UNM, where there's been substantial effort to make sure that medical school tuition is substantially less than the national average, students still graduate with significant debt. So it's hard, people are burned out, it's expensive. Why do people keep choosing these professions? Why do people stay in them? I truly believe it's because, like many of you here today, people feel called to this work. There's an old saying that says medicine was conceived out of sympathy and born out of necessity. In other words, as humans, we care about other people when they are in pain, and we want to relieve that pain. So how can we, as an academic teaching hospital, create the model that best supports our providers and enable them to do the work they're called to do? When I talked about those tools and techniques for improving communication, how do we make sure that they see those as valuable and not as one more added task? There's a lot of different methodologies you can use to improve efficiency. Lots of different techniques, vocabularies. I'm not a disciple of any particular one. But there is a principle in Lean that I think applies. The people who do the work know the work best. So the academic teaching hospital of the future needs to integrate our frontline physicians, frontline staff, look at our processes. Making the work more efficient has to also mean making the work easier for them. It has to be sustainable. And the only way we do that is by working together, by communicating across disciplines and across specialties. So that brings us to kind of the last strand, as it were. You've got the clinical, education, research. Disease-specific research obviously continues to be important, right? I mean, we're not going to just quit researching diseases. But we also need to expand our research into social determinants of health and health disparities. Hippocrates said, "It is far more important to know what person has the disease than what disease the person has." I'm going to say that one more time because it's really important I get the words in the right order, obviously. It's far more important to know what person the disease has than what disease the person has. We need to expand our research into what our communities are experiencing and how what we do impacts them. To understand how impactful this work can be, just reflect for a minute on what is the demographic factor that most strongly correlates with life expectancy. What single factor most clearly correlates with life expectancy? Is it age? Gender? Educational status? It's zip code. Zip code is the demographic factor that most strongly correlates with life expectancy. And if you think about it, that makes sense, right? Your zip code is your neighborhood, it's your community. And your community generally correlates with your level of educational attainment, the level of violence you experience, the availability of healthy food choices. We need to work to research and understand how those impact health. And then we need to adapt the care we provide to reduce disparities in healthcare. This is the only academic teaching hospital in the state. We have a unique opportunity and an accompanying responsibility to create the academic teaching hospital of the future for New Mexico. We can provide clinical care that is team-based, that communicates with our patients, that is high quality and safe. We can partner and produce education for future healthcare providers, train folks in safe, high-quality clinical care, and in the communication and coordination that's necessary to create that. We can work with the Clinical and Translational Science Center and others to research community engagement and health. That braid, those 3 strands that are the mission of the academic teaching hospital, they're woven into the fabric of a community. Care for us doesn't just begin and end at our doors. It extends out into the community. Or to paraphrase John Donne, no hospital is an island. Patients don't just swim up to us for care and then swim away, and we don't see them again until they come back. We have to extend out into our communities with community health workers, telehealth, health disparities research. We have a unique opportunity. We can care for one another better. We can move from that disease-focused model to a care-focused model. And I'm hoping that we get the chance to do that. Thank you.
So Kate, we'll take some questions from the audience and have a dialogue. And so if we could just start to move the microphones around. If you could just raise your hand, please. While they're doing that, I've got a first question for you.
Awesome.
So you talk about transformation, whether it's transformation of the clinical model or the financial model or our approach to the patient as a whole. Those transformations just don't happen. And some of the business literature would say that even with good leadership and good vision and a good history of execution, that transformative change really only happens 30% of the time that you go after it. What do you think distinguishes organizations that are able to successfully make that journey from those that aren't?
Thank you. That's a good question. I think one of the keys, and one thing I've learned in my experience in culture change in organizations is that, a convoy only moves at the speed of the slowest ship, right? I said that to somebody yesterday. And so we really have to be transparent in our communication around what we are doing and why we are doing it. We all have to kind of agree, and what makes organizations that change successful is on that first principle that change is needed. If 80% of the people in this room don't think anything needs to be different, nothing's probably going to be different. We have to believe that we can do better and we want to do better. But just wanting to be better isn't enough by itself, right? We have to have the tools, we have to have the communication, and we have to be really transparent with one another. Building trust is hard. And in this sort of academic environment, there tends to be really sort of lines of division between whether it's departments and divisions, hospitals and the medical group. There's a lot of different ways we slice and dice and identify ourselves. And the only way you overcome those sort of divisions is through communication. It's impossible to over-communicate. And you have to do it a lot of different ways too, right? Some people are visual learners, some people need to hear it. You can email people and you'll get about 10% of them. There's a lot of different ways you have to approach it. But I would say organizations that have been successful in managing change have correctly identified that they are collectively committed to change, have figured out how to get tools for change that are helpful to the frontline staff and not an impediment to them doing their work, so they have to come up with a workaround for that, and then continue moving forward. Hope that helps.
Hello, Nicole Rogers from the Department of Nursing Excellence. I've been with the hospital for about 2.5 years. Thank you so much for being here. My question is a two-parter. One is, I have a passion for our why, and why is it that you work in healthcare to begin with, and why you want this position. And the second is your opinion on transformational leaders. I think, and that's something that we have an opportunity to improve on. So what is your opinion on transformational leaders, and are you a transformational leader?
So why healthcare and why this position? So why healthcare? Because personally, and this sounds awful because I apologize in advance to people who have nothing to do with healthcare, but I'm going to tell you why everybody here does have something to do with healthcare. I think there's no more impactful work you can do. Literally, it is people's lives or deaths. And all work is important, all work is honorable. But this work in particular impacts everybody through their whole life. Not all of us is a doctor, not all of us is a nurse. At some point, every single one of us will be a patient. And it matters how we do that. So why are each of us in healthcare, regardless of what your job is? Because at some level, what you do impacts that bedside care delivery. Some of you directly, some of you more indirectly. But whether you're a tray passer or a neurosurgeon, you are impacting the experience of that patient. No offense to the neurosurgeons. So transformational leaders. Do I think I am one, and what do I think they are? I have been fortunate enough to have had the experience of leading transformation in more than one setting. And in my current setting, actually, we acquired St. Louis University Hospital from a for-profit hospital company. For-profit hospital operators provide health care, and they do their business, and they're good at it. But their why is different than our why. Their why is to provide a return for their shareholders, and that's appropriate. That is what they do. For me personally, and for the culture that I seek to build, that is not enough. We have to do that, obviously. We have to have a margin. You can't meet your mission if you don't have some margin. But why we do it is to provide the care to people that you would want provided to your families. To be that reassurance. Sister Mary Jean Ryan, who was the first CEO of SSM Health, where I work now, she's retired now. She used to say, you can't always cure, but you can't always care. And that is true. We try to always cure, but when we can't, we still can care. What else?
Thanks for coming out. Actually, my wife is from U-City.
Oh, great. I grew up there.
So I'm Steve Liu. I'm one of the general surgeons here. I've been at UNM in August, it'll be 18 years. I was a trauma medical director for 10 years, and now I'm fortunate enough to be the chair-elect for the Physicians Advisory Group.
Oh, fantastic.
So,
Succeeding Dr. Ivers, is that right?
Yeah, Melissa Ivers is our current chair. I don't know if she's here. Melissa? Is Kendall here? So I'm here kind of, I guess, speaking for the PAG. I think that we're really, really heartened to hear that, again, the belief in the mission of the larger community, the commitment to the multiple strands of the mission in terms of, service, education, research, and particularly, this empowerment of the front line, I think, is something that we've all been crying out for. And so, despite, and one thing that Studer and, Prescott have always said is that that UNM is remarkable for the commitment of both the hospital and the provider side to that idea of the larger mission. So everyone is amazingly aligned behind this idea that we should commit to the community, right? And that people are fulfilling, we're here to heal the sick and save lives. Despite that, we have the lowest engagement scores of any academic medical center. Well, maybe there's one below us now. But literally the floor.
So there's nowhere to go but up.
There's nowhere to go but up. So one, why do you think that is? And then the second question is, I think that, again, you've really spoken about this need for continuum of care, patient-focused care, efficiency, quality and safety. Mm-hmm. And often, those involve hard trade-offs in terms of, in the short term at least, that there may be immediate financial, that if everyone looks at it from their standpoint, right, mm-hmm. that they will be penalized from a throughput or an access or a financial production standpoint in the service of these larger goals, which we know are important in the long run, mm-hmm. but are not immediately profitable to an individual silo in the short run. Mm-hmm. And how do you propose to break through those so that these larger collective goals can be realized?
So it's kind of a long question. I'll try to cover the component parts. So first of all, in terms of why I think physician engagement and staff engagement may be a little challenging. there is a phenomenon that sets in. And I'm going to tell a story I've actually told several times already. And where people don't think they have the power to make a difference. They don't think in their universe there is the power to do something differently. And when that sets in, you do see lower engagement because it's not that people aren't working hard. People are doing the heroic to achieve the ordinary, honestly. But they don't feel like they can impact change in what's happening to them. And they develop this sort of mentality of, well, it's just happening to me, I can't fix it. And that is disheartening. And to give you an example from a prior life, behavioral health unit, adult acute, there's a security guard on the unit. The security guard has a chair, regular chair, like one of the ones up here. Security guard gets up, is walking around. Patient throws the chair. Big kerfuffle, de-escalate the patient, get the chair back, put the security guard back, great. Time passes, security guard gets up, walks around, same patient, throws the chair. Big kerfuffle, de-escalate the patient, put the chair back, put the security guard back. Round 3. Security guard gets up, starts walking around, same patient, throws the chair. Kerfuffle, de-escalation, reseating. Nurse manager comes on the unit because it's been a bit of a kerfuffle all morning. And she says, "Why didn't you move the chair?" And the answer was, "Can we do that?" Okay? Now that story, to me, it perfectly illustrates what happens in this kind of situation where people don't feel empowered to do something in their immediate vicinity. They're like, pick up a chair and take it out of the environment. That's not a huge step. You don't need a committee to approve that. You don't need to go through 3 layers of somebody writing a policy about how the chair should work and where the chair should be and where the chair should go. You can just pick up the chair and move it. But the mentality that sets in that gets people to a place where they don't think they can move the chair, that's the culture you have to address. And it's not that the people who didn't move the chair were stupid or didn't know that they should move the chair or didn't think, wow, this is a problem that keeps repeating itself. But they didn't feel internally that they could do something about it. And the way that usually starts to set in is because people bring forward ideas and either somebody doesn't listen to them at all, that's possibility number 1, which isn't good. Even more disheartening, though, is possibility number 2, which is somebody listens to them and goes, oh yeah, that's a great idea, and then nothing ever happens, right? So in that scenario, after you've brought forward, your ideas, your thoughts a few times and nothing's happened, you just get kind of tired of bringing forward your ideas. So you just kind of retreat to your group, you work with your team, you do what you can or what you think you can, and so you feel like you're really working for the mission, you feel like you're really caring for the patient, but you're not living in the broader context of how to make the system work better because you're just done. You've exhausted all the emotion you can put into this thing, and nothing's happened. So I don't know that that's what's happened, but often in situations like this, that is kind of what leads to that sort of feeling or emotion. So how do you fix that? Well, a couple things. The first one is, obviously, you have to listen to the ideas people bring you. But the second one is you have to be out there asking them for ideas. And then you have to act on them. You have to choose the things that are actionable and figure out how to do them. Now, a good chunk of the time, the idea somebody's going to bring you is going to be, and we need to do something with the electronic medical record. That is often one of the things on the list of, and if just that did this, everything would be magically fixed. Well, there are things about that that are true. There are things that could be improved. But there are also things about that that really what you're talking about is a process step, and you need to think about how do we address the process step. So really diving in on, okay, what is it we're actually trying to fix? Kind of coming full circle to the what is the process and what is our goal? So I would say that's kind of how you start to address that and build it. And once people start to experience that things do change, that stuff does happen, it starts to get easier. Because then they start to get more engaged, and then more things come forward, and then things become more efficient, and then it gets easier, and then it keeps going. Cycles build on themselves, virtuous or otherwise. So what you have to do is start that virtuous cycle. I think that covered most of it. What else?
Good morning.
Good morning.
In today's business environment, there's, whether private, public, healthcare, great leaders have to make tough decisions. And I think sometimes with even creating efficiency, you have to make tough decisions. If you are selected for this position, how do you balance the need to come in and build relationships, but at the same time, make tough decisions?
So thank you for asking that. I want to be real clear about expectations. A long time ago, when I first started in the practice of law, I had a partner tell me, the practice of law is nothing more than the management of expectations. Which isn't entirely true, but there is a lot of truth to it. And it's the same thing in life, right? It's setting the, okay, what do we think is going to happen next? So first of all, I do not expect, nor should you, that if I get this job on day one, I'm massively going to make a whole bunch of decisions that immediately impact everybody. Because what I know and what I have learned in the course of my life is that there's a huge, vast, enormous, infinite amount of stuff I don't know. So the first step really is learning what's here, learning who is here, learning what we do now. I used to tell my kids all the time, because I'm a horrible mother and an evil person, you have 2 ears and 1 mouth so you can listen twice as much as you talk. It didn't work with all of them, but it's the same philosophy, right? It's first you have to learn. You have to understand the context that you're in. You have to understand where you are. And as you develop that knowledge and as you learn the context and as you understand what's working well, how do we celebrate those successes? Because that's something people forget to do a lot of times. In an environment where people are kind of disheartened, they forget to say, whoa, we knocked that one out of the park. It's like, okay, well, we did that. Let's go do something else and be miserable about it. I mean, it really is first recognizing, okay, what's going well? What can we talk about that we're really proud of, that we're excited about, that's awesome? And what are the opportunities that we need to work on? And one of the things that I think is really important, and people kind of overlook this, is in terms of what's not going well, when you talk about decisions to be made, the question we should always be asking ourselves is what went wrong, not who did something wrong. Because what went wrong is a question that addresses the process that created the opportunity for something to happen. Who did something wrong just identifies somebody you can say, well, hey, that was your fault. Sorry. And then even if you somehow, yell at that person, wave your arms, make them feel bad, if you don't change the process, whether it's them or somebody else, the thing that went wrong is going to happen again. So it's moving to that sort of thinking about the process, thinking about how we do what we do, and how do we make it right. And then in balancing those decisions, you have to have kind of identified, okay, what's your vision? What's your true north? What's whatever language you like to use? What's the lighthouse you're rowing toward? Because it is our job as leaders to set where's the lighthouse? And the next part of the job is getting everybody in the boat, then getting all the oars in the water instead of batting around at each other, then all rowing in the same direction, then making sure the direction is the lighthouse, right? None of that happens in 5 minutes. It requires a lot of relationships. It requires trust. It requires communication. It requires understanding that you have the right lighthouse, and it's not like some blinking light from a car somewhere over here and oops, we hit the rocks. You have the right lighthouse. You've kind of engaged the group. You understand what the priorities are. You know what's important. And sometimes the decisions you make are not going to be popular. But what I have learned is that even when you make unpopular decisions, if you are rational, you are fair, and you can explain why you decided what you decided, people might not like it, but they will understand it. They will get it. They'll be like, yeah, I know. I really wanted that, but I get that, that compared to this, because of where we know we need to go, we need to do this. People understand. What else? Yes, ma'am.
Good morning. My name is Kim Bolton. I'm one of the nursing directors here at the hospital. And I'm just wondering how your team and frontline staff would describe you and why you're leaving them after a relatively short tenure.
So how my team and frontline staff would describe me, I was just telling the folks up here, and I might get a little choked up telling the story, actually. So this is a public search, right? And so I had to let not only my one-ups, but my team know that I would be here and interviewing. And there was quite a bit of crying. So when I moved from St. Mary's to St. Louis General Hospital, a large number of people came with me. And that was not a small task, because for a bunch of different logistical reasons associated with the acquisition of the hospital, they had to quit SSM Health as an organization. So pension, seniority, vacation, and start over at SLU Hospital as employees of SLU Hospital. My chief nursing officer, administrative director of nursing, my assistant, quite a few nurses. I got in a little trouble, but those folks followed me. And so today, being here and having to tell them, okay, I'm looking at this opportunity and I'm considering making this move. It was hard and it was sad, but this morning I got texts from so many people saying, good luck, you're going to do great. And that's pretty awesome. So I think the way they would describe me is I'm clear. I let you know what my expectations are. I believe that we're all on the same team. And I understand that my job is to give you the tools to do your job and figure out how to remove the barriers so you can do what you know best how to do. So why would I consider leaving there? I love that team. I'm sure I would love this team. I love that work. I've been coming to New Mexico since I was a little girl. And it's always been a place that I am very fond of. It's the first place I ever saw mountains, and Mike Ciccarelli made fun of me about that because I'm like, those aren't really mountains. But I was super excited about it. I was like, ah! This place has a special place in my heart. And as you probably know, the last person in this job was here a fairly long time. So this job doesn't come open frequently. It's a once-in-a-career opportunity. And it's an opportunity to do a job similar to what I'm doing now in terms of level 1 trauma center. But in St. Louis, we're not the only level 1 trauma center. The scope of responsibility here is substantially greater because of that, because of the place this place holds in the state, in the region, and in the community. And so to me, it's a very appealing option. It's hard. I'm not going to say that I'm going to just go burning out of St. Louis like, see ya, wouldn't want to be ya. But I think it is an opportunity that's not going to come along again. And so that's why I'm here. What else?
Hi, my name is Elle Goldberg. I'm a data analyst in the Quality Outcomes Department. I've worked here for 3 years. So my question to you, you speak a lot about quality and improvement, and so it's actually 2 parts. So the first part is, what do you think UNMH does well currently? And then the second part is, if you had infinite resources, so no limit on money, staffing, anything like that, what would you love to do as a CEO in this position if you had everything at your feet, no limits?
Well, I'm sure that everybody over here is super excited to hear me get no limits. Awesome, go for that. Okay, so first of all, in terms of what I think we do well, again, I obviously don't know everything that's going on here, so I will not pretend that I'm going to hit all the high points that there are. But I think the first thing that has come across most strongly from everybody is the sense of teamwork, the sense of engagement, the sense of commitment people here have to the mission. I have not met a single person here who is not very clear that they are committed to this mission, that they love this place, and that they love serving this patient population. And I think that is incredibly impressive. I think that is a strength we can build on. I think that is something that definitely is an opportunity going forward. I think another thing that we do well is we really provide those services for folks coming in from across the state. When we have to make a trauma available, we make it available. We struggle with getting everybody else through the house. We have opportunities there. But we get done what has to get done. We have our priorities in order. We get the folks who need to be seen only here be seen. So that's, I think, the things that we can build on and be proud of are, we know what our priorities are. We know what our mission is. We just need to figure out some better tools for managing our way through the operations of that. If I had unlimited resources, I would say probably the biggest thing to do is, and I know that Mike has been working on this, is let's figure out how to use the data we have in an actionable way. Let's build the business intelligence and analysis tools that will help us really resource the areas that need it and understand all the data that we have. That's a thing that, because we understandably want to put all the resources we can at the bedside, we tend to kind of under-allocate to. But by doing that, we understand population health, we understand how we can manage outcomes in the community. We get better at everything we do if we do the investment in, let's understand what we actually are aware of. It's all out there, we have it, but we don't actually know or know how to use it. Yes, ma'am.
Good morning. I'm Chris Sanchez. I'm the Executive Director for Ambulatory Business Operations, but one of my roles is a health system-wide focus on diversity, equity, and inclusion.
Oh, great.
So I was really happy to hear you talk about the need for more research into health disparities and responsibility to community. My question is about what your philosophy is in terms of maybe the top 3 priorities you believe need to be in place for a robust DEI program.
For a robust
Diversity, equity, and inclusion program at an academic center.
So I think one of the things that happens, and this is kind of melding the top 3 together, really, is we set ourselves a goal of diversity in our workplace or wherever it is, and then we just start going to look for who can fill those spots right now. What we don't do as well as we could is start at the beginning and build the pipeline. So one of the things we've done in St. Louis, a couple of ways we've done this, are really work with not only our schools, so high schools and middle schools, with the middle schools going into the schools, with the high schools bringing volunteers, to really develop that interest in healthcare and healthcare careers, and that understanding that there is more than just being a doctor available in healthcare. Doctor is good and important, and we need to do that too, but there is more available, and people might be interested in things they don't even know exist. So working with our schools, kind of building that pipeline. Working with community organizations. So how do we make sure that folks have that opportunity to participate? And diversity means a lot of different things. So one of the things we're working on is sort of an ex-offender pipeline, for example. There's a lot of people who have criminal convictions, right, who can't find work. Are there places where we can include those folks and improve the socioeconomic status of our community? We obviously clearly have to deal with making sure they have appropriate licenses and they can be in the jobs that we want to place them in and make sure those matches are good. But we have to think about diversity broadly, and we have to build the pipeline and build the opportunities for people. And we have to be active in identifying that. We can't just say, okay, we posted a job and everybody should just apply and it'll be great. We need to build the interest, build the educational infrastructure, support our communities, and build the way to get to the place where when we say, okay, here's a job, we actually have a nice, diverse group of folks to include in that pool. What else? Yes?
Can I talk loud?
You can just yell at me, that's okay.
I'm Nick Estes, I'm on the board of the hospital.
Yes,
And we had a chance to meet before, so it's nice to see you again.
Thank you.
Thanks for coming. I don't think I asked you. American healthcare is terribly expensive compared to Europe and Japan, the other advanced countries, for apparently approximately the same outcomes. Do you have
sometimes
any
worse.
thought, in some cases worse, do you have any thoughts for us on how the cost of healthcare could be lessened in America and still have high quality?
So I think there's obviously a lot of very smart people who have been tackling that subject for a long time. So this is borrowing from a lot of other people's thinking on that topic. But first of all, American healthcare, we are the best in the world at rescue care. We do the best job there is at trauma. We do the best job there is at intervening in that acute situation and doing something. We're awesome at it. Those are expensive services to provide, but we do it really, really well. What other countries do differently and less expensively than we do, and we haven't figured out yet how to do as well, is all of the things that come before that. Managing those chronic conditions, primary care, access in the community. We haven't gotten as good at sort of the baseline health care as we could. And part of that, I think, is because of that disease-focused model I was talking about before. We're not looking at the patient and thinking about, okay, this patient is a diabetic. We need to make sure that they have education on food. We need to understand what food is available to them. We need to understand that they know how to use their insulin. Instead, we're saying, okay, they've got a heart condition, so the cardiologist sees them. We've got this condition, so somebody else is seeing them for that. We haven't gotten to the point of integrating ourselves well enough to manage that care in a way that we don't duplicate a lot of testing, duplicate a lot of services, duplicate visits, and that gets expensive. And so I think as we think holistically about in the system, how do we reduce cost? Part of it has to be in really getting further out in the continuum of care, farther out than you're at the cardiologist, back to, okay, you have a primary care relationship, whether it's family medicine or an internist, even back to you have a community health worker who can check in with you to make sure that you're doing your insulin correctly and managing your diabetes. We have to work this part that we haven't paid as much attention to so that when that acute care is needed, we have it, it's available, it's appropriate, but we've kind of titrated out that sort of expensive duplication in the middle where we haven't coordinated well with each other. Yes? Oh, sorry.
Hi, my name is John Bullitt. I work in quality outcomes with Al.
Great.
And I've been here a little short of 2 years, but I started here decades ago as a respiratory therapist, went into academics, kind of full circle, and ended back here. And one of the things I do, I work in public reporting, so I'm very familiar with leapfrog, I started and all that. But as an adjunct to that, I've also gotten fairly involved with and seen a lot of research around patient-family engagement and giving a voice.
Right.
And how critical it is for them to be involved in their own care and their families and in coordination of care and transition of care. And I'm just, like many hospitals, I think we're in our infancy in terms of some of the formal things you can do around patient-family engagement and getting good patient-family advocacy happening. And I'm just curious what experience you have with that and what sort of things you would try to do to shift that culture to a more patient-family engagement model.
Well, I think the first thing is kind of back to what I was talking about earlier, shifting to care focus instead of disease focus, right? So the patient in the bed is not COPD. The patient in the bed is John Smith, right? So thinking about it from that perspective, patients respond to that. Patients and families respond to, let's talk to them as a human. Let's listen to them as a human. Let's make that connection. And so there's a lot of ways we can do that, and we've done a ton of different things. Because when you think about your Press Ganey scores, for example, and the questionnaires that you get, when you dive down into that, you end up doing things like, okay, quietness at the hospital. We have semi-private rooms, so there's never going to be like the awesome score on quietness. We're going to work at it, but we're not going to have carpeted hallways, one patient to a room, and it's going to be so delightfully silent. So, okay, what else can we do? People will forgive okay, I understand that I had to share a room because we're busy, or I understand that, you had to go running down the hall to a code, so there was noise going past in the hall, if the rest of their experience is good. So we've done things, in terms of housekeeping, in terms of food service, really to create a way, and it doesn't cost more. It's all about sort of courtesy and respect training, and really teaching people how to interact, because there's so many people who go in and out of a patient's room every day. We have tons of opportunities to interact with each of those people, and we can make each of those interactions better. And that's really, I think, what drives a lot of it. The other thing, and I don't know, because I don't know enough about the different sort of communities and councils and things that are here, but generally speaking, it's a good idea to have a patient advisory board. So if you already have that, that's fantastic. But we have something like that. So you get direct feedback from people who've experienced it or their family members, and that's helpful.
So we'll do a question from Dr. Liu, and then I'd also like we'll wrap up after that, but I'd just like to make sure that if we have a community member here that would like to also ask a final question, please raise your hand. And if not, we'll make Dr. Liu the last question.
So in our current culture change initiative, the Mission Excellence, it's, as it's structured, it's very strongly bifurcated there's a hospital side and really kind of a provider side. And it kind of parallels the structure of the hospital's health system and the medical group. Can you comment on how you've managed culture change initiatives? Do you feel like in your experience that that's a similar experience managing those two sides, or are there different challenges, and how have you dealt with those?
It's extremely common to have the hospital side, physician side, maybe not be overlapping completely or at all. So in my experience, what has worked with that is having connectivity at multiple levels between the physician organization and the hospital side. That can be everything from the MEC and hospital administration to the sort of nursing director, medical director dyads, to literally at the bedside, the team in the ICU all works together well. It has to go all the way up and down. And the way you do that is by having common sets of goals, common priorities, and common approaches. So if you pick an initiative, universal protocol is a good example. Let's say you decide that you're going to focus on really having 100% wrong site surgeries, and you're going to do that by universal protocol, and here's what you're going to do, and here are the steps. You really need engagement from both sides, working through, okay, what does that look like? How do we train on it? How do we implement it? And then how do we make sure that we're doing it? How do we audit it? So a lot of it is really putting together teams or pods or whatever you want to call it all along the way, so that those folks can work together regularly and build relationships. Because no matter how advanced technology gets, it is still true that every human interaction is a person-to-person connection. And if you know the person, or if you've experienced working with the person, you're going to be more open to trusting what they tell you, to knowing how to move forward with them, and to thinking about yourself working in partnership with them. So.
Well, Kate, thank you very much for being
Thank
here
you.
today, for your thoughtful presentation. But also for what you do for healthcare, both in your community and as being a national thought leader. Now, I'd also like to finish up today, though, by just saying thank you to everyone in the room. This is a very important process, as we discussed at the very beginning of this, and your participation in this to help ensure that we select the best possible candidate for the UNM Hospital CEO. We wouldn't be able to do that without your participation and input, so please fill out the evaluation forms that we provided. And I'd also like to say thank you for taking the time to be here today, and also thank you for everything that you do to help UNM be a great place to work, a great place to receive care, and a great place to learn. So thank you very much.
Thank you.